pressure and the skills, we can probably be done by about 1, thereabout.
Like our full-on production company up here recording a bunch of stuff. All right, so as Jamie and Danny were saying, the state has added some things to the AEMT scope of practice, and the service has chosen to adopt that. And the things that are added to the scope of practice are going to be CPAPs, Atrovent, which is a mucolytic. It's the second half of the dual med treatment besides albuterol. Antiemetic is going to be Zofran, cardiac epinephrine. Your scope or your ability to treat allergic reactions is going to be expanded by adding Benadryl to the AEMT protocol. And you're going to be allowed to do adult IOs in the proximal tibia. Along with, you're going to have some pain management options. The pain management options are new to the service entirely. It's even new to the paramedics. So we'll be talking to them about that later. But as Danny was saying, the reason why we're doing this is a limited number of paramedics entering the workforce. We've got to maximize the care provided at each licensure level. Better outcomes for the patient, greater contribution from each member of the team will better prepare EMS for the future. So the first thing we're going to go over is CPAP, continuous positive airway pressure. So we use CPAPs to treat COPD. COPD is a group of diseases that causes airflow blockage and breathing related problems. So one of the problems with COPD, or the major problem with COPD, is you can't get air out. So as you know, if you can't get air out, that means you can't get air in. So the patients, when we say they're retaining CO2, they're retaining spent air. Air that they've already inhaled and got the good out of is being stacked up in their lungs and they can't fully get it out. The problems, the three characteristics of reactive airway disease are inflammation, airway constriction, and excessive mucus production. The EMT was able to treat the airway constriction, and that was the only thing they were really able to do for a patient that was having an issue with reactive airway disease. The decreased tidal volume is due to loss of lung elasticity. Tidal volume is the amount of air that you inhale and exhale with each breath. We lose that when we develop problems like emphysema. The air sacs, the alveoli become stiff, they don't move as well, and often that's caused from the allergens in the air. Because we live in East Tennessee, the allergens in the air quality here is significantly worse than it is in other parts of the country, along with cigarette smoking and things like that are very high here. Chemical exposures from factories and coal miners, that also plays a role in why we have so much airway issues here. So we got to understand why this works and how it works. I feel like if people understand why we're doing what we're doing, or why we're asking you to do something, you're more likely to do the right thing at the right time. So diffusion, it's a scientific word that allows for particles to move from an area of higher concentration to an area of lower concentration. The best way I can explain that to you is if you take an oxygen cylinder and you cram 2,000 psi of oxygen in it, all that air wants to come out. So if we crack the valve on the top, it tries to balance that pressure with the outside air. So things that are in an area of tight concentration, there's a bunch of them in there together, we want to see those rush out and get to the outside air and balance together. When you breathe in, the air that you breathe in has 21% oxygen in it. Your bloodstream has a lower concentration of oxygen, and those particles try to balance out through diffusion. Partial pressure, that increases the likelihood that gas exchange will occur. The partial pressure of oxygen of ambient air at sea level is 160 milligrams or milliliters of mercury. The way we increase that is through a CPAP. So if I increase the pressure, like I've increased the pressure in an oxygen cylinder, it's more likely that gas is going to try to escape or to try to push its way into our bloodstream. When we apply a CPAP, we're artificially increasing the partial pressure by intervals of 5. So it goes from 5 to 15 to 20. We wouldn't use more than 20 of PEEP, or positive end expiratory pressure, in pre-hospital medicine. You might see that on a transfer when you take a patient from the hospital down to Knoxville or something, and we saw higher peak pressures during a time when patients had COVID. A little peril of knowledge comes from this lesson. You talk about a lot of times we see the weather changes in atmospheric pressure cause people to have difficulty breathing. You get used to living at a certain level, and if that changes due to a weather front, change of seasons, or a change in altitude, you start having difficulty breathing if you have any type of airway disease. Another option for the CPAP, or another disease process that the CPAP treats, is congestive heart failure. Left-sided heart failure leads to pulmonary congestion. When fluid fills the alveolar spaces, gas cannot be exchanged. This leads to hypoxia and decreased air movement. The patient is essentially drowning in their own fluid. Used to, the EMT was without any kind of treatment options for this, other than oxygen and drive fast. So how does a CPAP help? Well, a CPAP is going to force that air or force that fluid back out into the vascular space so that fluid can be circulated and eliminated by the kidneys. The appropriate level of intervention in breathing abnormalities is directly related to the work of breathing and the ability of the patient to maintain that work. All muscle activity requires oxygen. The diaphragm muscle is the most efficient at breathing. Its whole job in life is to breathe. When we start using muscles other than the diaphragm to help us breathe, those muscles are not very good at it, so they burn more oxygen. When you see a patient who's bent over and they're doing this, those intercostal muscles, those sternocleidomastoid muscles that are trying to help them breathe are not efficient. They're like a big old diesel truck driving down the road. They just don't get very good fuel economy. Well, these rib spaces or these intercostal muscles, they don't give much return on the amount of effort they're putting out. The ability of the patient to maintain this increased workload, it depends on their age, their physical conditioning, the degree of cardiopulmonary reserve, and what other medical problems they might have. So, Grandpa, who's 65 years old, he's got COPD, he's also got arthritis, he hasn't moved off the couch in the last 10 years since he retired from the factory. He's going to have very little reserve or very little ability to keep this amount of effort. So how do we help that? Well, a CPAP helps lighten the workload that he feels when he tries to breathe. Increased workload of breathing can be observed. You can see it. The patient tells you they are short of breath. That's a subjective complaint. Objectively, though, what do you see when you look at the patient? I always think of objective and object. When I look at the patient, I can see that they're really struggling. You know, they've got that pursed lip breathing. Speaking of pursed lip breathing, when they exhale and they're doing this, that's called auto PEEP. That's your body's own CPAP. They do that to try to hold positive pressure to keep their alveoli open longer. It's a natural response. They develop that when they start having breathing difficulty. I've already talked about a little bit about how this works, but the CPAP will force air into the lungs and displace the fluid occupying the alveolar spaces. So you can see this fluid over here in the air sac. When the air sac or the alveoli is coated with liquid, the gas cannot pass through the liquid. When you apply positive pressure, this will allow for gas exchange and help with lung expansion. It also increases the amount of inhaled oxygen because your CPAP is hooked to 100% O2. Here's a video from the manufacturer of the CPAP that we carry, and I'm going to play that for you guys. I think it helps to hear it explained from multiple different sources.
Welcome to the Pulmonine video in service. Today, members of our team will walk you through the O2 Max. We thank you for choosing the O2 Max as your product of choice. Enjoy.
Their music's loud, but they're talking soft.
The O2 Max with nebulizer comes in a small pack with a label that clearly illustrates the contents and size. Within the bag, you will see the following items: a directions for use, one bitrack ED mask in a Ziploc bag, a nebulizer which is sealed in its own bag to use at a later time if you're not going to use it with your patient, and the O2 Max generator itself, vent tubing and elbow. This is part of the system. It comes pre-connected to enable quick and easy CPAP application. Now let's work our way through the system in a logical way from how the oxygen flows through the system from your O2 supply to the patient. At the distal end, you will either see a green screw denoting oxygen connection that is to be screwed to the high pressure port, also known as a DIS or PTO. Or you may see a quick connect. When combined with a quick connect pigtail on your cylinder, it makes for a seamless transition from bedside to ambulance and to the hospital wall. Minimizing flow disruption in CPAP is vital to optimizing patient outcomes. To understand why the O2 Max utilizes a high pressure port, we need to look at the two outlets we often deal with on an EMS regulator and wall outlet. The wall outlet and high pressure port on a regulator are all unrestricted flow. When we use unrestricted flow, we get a constant pressure that is not dependent on the tank contents. If we use a flow meter, this is restricted flow. As the cylinder contents get low, the flow drops. As a pre-hospital provider, this means you have to constantly monitor the CPAP device to ensure your patient is receiving therapeutic CPAP. With the O2 Max, you can plug in the device and have instant CPAP that doesn't require constant attention, which means you can spend more time monitoring and treating your patient.
From the connection, we have a clear tube that leads to the O2 Max generator. This tube is feeding 15 liters per minute of flow from the oxygen source at 50 psi from the high pressure port into the generator. The generator then entrains or pulls in further 125 liters per minute of ambient air. It gives 140 liters per minute of flow. More importantly, that air is being entrained is also being filtered by a bacterial and viral filter that is also catching potential allergens. This is important as most of the patients we're treating with CPAP already have compromised lung damage, so adding contaminants is not ideal. The O2 Max is a closed system and provides clean, filtered CPAP pressure. This is also a good time to highlight the fact that the O2 Max is made in America. Because the O2 Max is made in America, we are subject to FDA quality regulations. That means that each O2 Max is tested here. This is also a great reason why we do not need a manometer to support our product. Each unit is tested and delivers the peak, flow, and FiO2 that is documented in our directions for use. Moving on from the generator, we come to our expandable hose. It can be extended to 72 inches or 6 feet as well as being recompressed should you need to. I recommend that you extend from the generator side and keep a hand-width compressed. This will help with reducing any potential noise due to the high flow the O2 Max delivers. Pulmodine uses expandable vent tubing on the O2 Max as it provides a more subtle and distributed flow to the patient's face, which leads to increased patient comfort and compliance. From the hose, we come to the elbow of the O2 Max. Depending on what product you purchase, it may look different. For this video, we will look at the most common system used worldwide, and that is a 3-set PEEP. Your system or hospital may use a fixed setting of PEEP, and if you have questions about this, please contact your local representative.
From the hose, we come to the anti-asphyxia valve. It's colored orange, so it's easy to see. Right now, there's no flow, so essentially, it's in its anti-asphyxia mode. If the patient was wearing the mask, the patient would be able to breathe through these two openings here. Once the flow starts, the flap will lift and occlude the two holes. The valve is now in CPAP mode. The key to this anti-asphyxia valve is the distance to the patient's mouth. It's very close, so it minimizes dead space should your oxygen supply fail. Moving on, we come to the PEEP valve. As you can see, this is a 3-set PEEP with settings of 5, 7.5, and 10. The valve comes out of the factory set.
So, he talked about that anti-asphyxia valve. How many times have you had a patient on CPAP and you get to the hospital and it's like, okay, hold your breath for a second. I'm gonna move this hose over. And you've got this sudden amount of anxiety, you've gotta hurry, you've gotta unplug this thing, and you gotta get it plugged back into the wall. Meantime, you drop it or something happens and your patient's like suffocating. Well, they were already having trouble breathing to start with, and now you've turned around and asked them to hold their breath. You've lost what integrity you had in that circuit and what you had with that patient built up, that I'm not gonna let you suffocate. Okay, maybe I am, just kidding, and I unplugged it. So with this anti-asphyxia valve, essentially when it loses pressure, that flap immediately opens and they're able to breathe ambient air so they're not choking to death. So that was a pretty important added feature. That was one of the kind of the downfall of the CPAP for a little while, that just one of the negative things about it that they've addressed with this. So.
First, interrupt your CPAP therapy. Check the check valve. However, now freeze up the low pressure port so we can see the disc go up and down, the PEEP valve numbers facing forward. As a visual reading, you will hear PEEP requires an increase in liter percentages of the O2 Max. From the hose, we come to the anti-asphyxia valve. It's colored orange, so it's easy to see. Right now, there's no flow, so essentially, it's in its anti-asphyxia mode. If the patient was wearing the mask, the patient would be able to breathe through these two openings here. Once the flow starts, the flap will lift and occlude the two holes. The valve is now in CPAP mode. The key to this anti-asphyxia valve is the distance to the patient's mouth. It's very close, so it minimizes dead space should your oxygen supply fail. Moving on, we come to the PEEP valve. As you can see, this is a 3-set PEEP with settings of 5, 7.5, and 10. The valve comes out of the factory set at 5. That means once you connect the O2 max to an oxygen source and turn the cylinder on, you have instant effective CPAP at 5 of PEEP. It doesn't get any simpler than that. One of the distinct advantages of the O2 max is that our PEEP is totally independent of the flow. That means when you increase the PEEP, the flow, FiO2, and cylinder run times are not affected. This is important in your sick patients that require high PEEP. In other systems, high PEEP requires an increase in liter flow, which in turn reduces cylinder run time. This is counterproductive in patients that need longer pressure times. Remember, in CPAP, time under pressure is key to better outcomes. To increase the PEEP from 5 to 7.5, you make one full turn. As well as the visual reading, you'll hear a click and feel a click. 3 ways to make sure you're dialed in. If you don't make the full turn and your valve is slightly off, the PEEP will only be about 0.5 PEEP off, so you're still within therapeutic range. On the sides are the exhalation ports where the patient exhales from. It's good practice to have the PEEP valve numbers facing forward so the exhalation ports are running left and right of the patient's face. So this is a comfort and compliance issue for the patient, so they are not breathing into their own face. You will notice that when the patient exhales, the disc goes up. When the patient inhales, the disc goes down. When you see the disc go up and down, you have a seal on your mask and effective CPAP. From the PEEP valve, we move down to the integrated nebulizer port. This was developed for the O2 max after we received user feedback. As we discussed earlier, the O2 max is connected to the high pressure port. This now frees up the low pressure port so we can nebulize and run CPAP off a single cylinder. With the integrated neb port, you no longer need to buy a T adapter when you also consider that we are including a nebulizer. Adopting the O2 max will result in low cost savings. Back to the nebulizer port. We provide a small cap to protect the check valve. However, this is a closed circuit and will work covered or uncovered. You will notice that when I push the check valve up, it opens the circuit and any nebulized medication will now be administered to the patient. Notice how instantaneous this is. You add nebulized medication instantly without any disruption in CPAP therapy. We include the continuous care nebulizer with a scored needleless entry port to add medication without having to interrupt your CPAP therapy. As I stated, the elbow, hose, and generator are all pre-connected. When you want to start CPAP, you will need to attach the BiTrack ED mask.
Our BiTrack full-face ED mask made in the USA offers several advantages over the competition. First, everything is made of silicone, including the forehead piece. The competition's masks are at times made of foam, which could cause skin breakdown on the forehead. Ours is easy to wipe clean and adjust due to our unique Omni clip. It adjusts both up, down, and in and out. Our BiTrack full-face ED mask also offers a floating dual lip style cushion, which allows the mask to float on the patient's face. Because the mask floats on the patient's face, it gives you many advantages over the competition. First being it helps prevent pressure ulcers from forming on the bridge of the nose, and it also prevents unwanted leak from happening. When you take the mask out of the package, the top 2 straps are pre-attached to the mask. The bottom 2 are detached from the mask. So the idea is attach the bottom 2 clips to the mask, size it properly with the Velcro, and remember there's 2 sets of Velcro. You can also undo the bottom 2 clips, lift it up 90 degrees, and give the patient medication.
And now, a complete product demonstration on the O2 Max.
First, open the bag and grab the generator from inside. Place the elbow of the circuit onto the mask. Take your generator and connect via the green disc fitted or quick connect to your oxygen source. Allow your patient to take the mask and hold it up to his or her face, and this will allow them to feel the oxygen flowing out and will reduce anxiety and increase compliance. Place the strap over their head and connect the bottom 2 clips. pull on the Velcro either side to get a good loose fit. You do not want to pull the mask too tightly or leaks will occur. This mask should float on the patient's face. Adjust the Omni clip in and out, up and down for an optimal fit.
To conclude our in-servicing, let's go over some of the accessories in this line. The O2 Max Trio is the first accessory. As we stated previously, the O2 Max has a fixed configuration that generates approximately 30% FiO2. Dr. Bledsoe stated in his clinical paper on FiO2 in the pre-hospital EMS market that 30% should be adequate. However, there are patients that will need an increase in FiO2. For this, we have the Trio. The Trio is sold separately too from approximately 30. It is easy lock oval. The last accessory is the O2 Rescue Filter. For the
So as far as CPAPs go, in the pre-hospital world, it's the best one you can get. We've seen these at several trade shows and conferences and such, and there's not really anything any better. If you remember the CPAPs we had before, the patients didn't like them. It was hard compliance. They didn't want to wear it. Part of the reason why you don't want to wear it is you're already struggling to breathe. You ride down the road, roll down the window of your car, and stick your head out the window and try to breathe. It takes your breath away for a second. So in a patient who's already anxious and already short of breath, it's going to be difficult to get them to wear the CPAP. That's why when he talked about putting the mask on, let them hold it. Here, I want you to hold this up to your face. During that time, you're getting the straps on, you're encouraging them, you're talking to them, explaining to them this is going to help you. Yes, I know it feels really weird to start with, and it might even feel like it's taking your breath away for a second, but once you get used to it, it's going to help you to breathe better. One of the other things he talked about there was how tight do you get the straps. This thing doesn't have to be cinched down. That's a silicone seal on there. The tighter you get it, the more likely it is to crease and leak. When it creases and leaks, then the patient's not going to get the full treatment. They're not going to get the effects of the positive pressure. Also, patients that have facial hair or any type of facial trauma, it's going to be difficult to get a seal. That's why facial trauma and facial hair a lot of times is a contraindication. It's relative. You can try it. If you can get it on and somebody that's got a beard or whatnot and it seals up around it, that'll be okay. You've also got some KY jelly on the truck. You could put that on the seal or on their face. Now these are just some old school tricks you can try that might help you get a good seal. At that point, you know, if it's bad enough, you're probably going to start looking at ALS intercept or starting to drive fast to the hospital because it might be something that requires a more advanced airway. The patient has to be awake. They have to be able to control their own airway. They have to be able to follow commands. The reason for this is if they start to throw up, they cough, they burp, they anything, whatever comes back up, if they're not able to control their airway, is going to end up in their lung because that positive pressure is going to push it back in there. If the COPD exacerbation and the CHF doesn't get them, the aspirated pneumonia is going to get them in the next few days if you've done this. So if the patient's not awake, we can't use the CPAP. Any patient that has a stoma or tracheostomy that they breathe through, because if you blow positive pressure air in through the face mask, that air is going to leak out the stoma opening, so it won't do them any good. It's also contraindicated in patients who have had chest trauma. So if they've been in a car wreck and they're complaining of shortness of breath and chest pain, then we're not going to be able to use a CPAP for that because it could turn a simple pneumothorax into a tension pneumothorax. The nebulizer comes in the kit. It's built in it for our old CPAPs. Anytime you wanted to give a nebulized breathing treatment, you had to open the CPAP to start with. Then you had to open up a dual neb mask or a mask nebulizer or a T-piece nebulizer and use the elbow and piece it all together and try to get it to work. And if you're lucky, you didn't have any leaks. During that time, when you're disconnecting and connecting all that, your patient's not getting the benefits of positive pressure. And as you heard what the man said, time under pressure is important to help push that fluid out and get those alveolar spaces open. So this comes pre-assembled with all the parts that you need. So what else can we do? So if we remember that the three problems with reactive airway disease is airway constriction, so we're treating that with the albuterol. The next thing it talks about is excessive mucus production. So how do we treat that? Atrovent, the second part of the Duoneb treatment that you've seen given so many times, you might not have understood or why you were doing that. The Atrovent, the ipratropium bromide, as it's labeled in the truck, is a 0.5 milligram package. You give the whole thing, mix it with one albuterol. It's an anticholinergic. So anticholinergic slows down the production of mucus and secretions. The patient might complain that their vision gets a little blurry, It's because it has the potential to dilate their pupils. It also might cause their mouth to get dry for obvious reasons because it decreases secretions. It's a bronchial smooth muscle relaxant mildly. It's not a rescue type product. It's designed for therapeutic effects. So we might not see the results of this in the field, but eventually over the next 15 to 20 minutes, the patient's gonna start having gradual improvement from it. The albuterol is a rapid onset type medication that will work quickly. So those are what we would do when you have a COPD, emphysema, reactive airway issue. Also with that built in was the congestive heart failure. There are paramedics who can't determine the difference between wet lung sounds versus just a typical COPD issue. There's doctors that can't do it. We don't need to really spend time trying to figure out if it's a CHF issue or a COPD issue. You can treat all the above. If what you're doing is not working, add something to it. So in our congestive heart failure protocol that you have there, we've added nitroglycerin paste to the AEMT protocol. So this is measured with the paper that you have in the truck. I've got some back here to show you if you're not familiar with it. Nitro paste is not commonly used. That's not something, I think me and probably 3 or 4 others were the only people that really ever used it, but it works very well in patients who have congestive heart failure. The onset time is 15 minutes. It dilates the vessels in the coronary arteries to allow more blood flow. So if fluid is a problem, then we need to increase the blood flow as well as push the fluid back out into the vascular space. We increase the amount of flow there in hopes that we can get that circulated back out into the vascular space so it's not in the lungs. The onset, again, is 15 minutes. The duration is 3 to 8 hours. Even after you wipe it off, it continues to absorb for up to an hour. In people who are a little thicker, myself included, it takes a little bit longer for the medicine to reach the target receptor sites because it's got to absorb through my skin. Therefore, if I wipe it off, then the duration, the amount of time it takes to stop working is going to be longer because there's some in that space in the adipose tissue that hasn't even made it to the receptor site yet. Anytime you touch nitro paste, the packaging, the tube, anything to do with it, you have to have gloves on. Because when someone uses nitro paste, they most all the time get some on their glove. They get some on their hand. Then they touch the tube and they put it back in the drawer. So when you go and you get it out and you touch the tube and you go, man, I'm burning up. Or you reach back to pull your hair out of your eyes or whatnot, you have now got nitro paste on your forehead. You're going to get a headache, and the worst case scenario is you could pass out due to hypotension. So anytime you're fooling with nitro paste, or for any drug for that matter, you should have gloves on. The silk tape that we have does not stick very well to that waxy parchment paper that this applies to. So the transport tape that's got the little dots in it, the 3M tape, sticks really well. I would suggest using that. You can use whatever you want to, but I don't think you'll get a very good stick unless you use the paper tape or the microsport tape. So we'll show you later, but the width of this line on the paper, these up and down arrows here are to tell you the width. That's how much of it you should squirt out. It's kind of like on the toothpaste. It says put a pea-sized amount on your toothbrush. Okay, so we're going to use one solid bead like you're putting caulk on something. One solid bead, 1 inch. And that's clearly marked on the paper, so you'll be able to see what you should do. But anytime you're using nitro paste or any type of nitrates period, you have to have an IV. You have to have an IV. If their blood pressure is less than or equal to 100, you cannot administer nitroglycerin. You must repeat their vital signs every 5 minutes. You'll hear that with every medication that we give. Any medication or any time we're treating a patient who's acutely ill, we should be monitoring vital signs every 5 minutes. My preference is that we check vital signs manually the first time, and then the monitor cycles and does it every 5 minutes thereafter. Patients who use phosphodiesterase inhibitors, Viagra and Cialis. So why is that such a big deal? You hear that on a lot of commercials and stuff. Phosphodiesterase is the enzyme that your body makes that breaks down nitrates. So if you take an inhibitor that would stop that enzyme from working, the nitrates continually build up and you have a much higher effect from them. Viagra and Cialis were invented as initially as a pulmonary hypertension medication to dilate the pulmonary arteries. They found out that it worked really well, and dudes were walking around and they couldn't roll out of bed in the morning because the tripod was extended. So they figured out that wasn't going to work. We couldn't give medication to people and have these old dudes walking around knocking stuff off the table in the morning. So they decided to remarket them as something they could use for erectile dysfunction. So that's why you hear that oftentimes when it's associated with nitrates. Serious drop in blood pressure occurs. It might be an uncomfortable question to ask, but if you're going to give somebody nitrates, we should be asking that question. So this combination treatment, the albuterol and Atrovent, the Atrovent slows the production of mucus in the lungs by inhibiting the effects of goblet cells. Goblet cells line the airway along with cilia. The cilia is the little hair-like projections in your airway that sweep all the mucus out. That's why when someone says, I quit smoking and my breathing got worse, it will for a little while. The cilia that had been paralyzed wakes up and it starts trying to sweep all that nastiness out of there. The patient develops a cough. They associate that with more trouble breathing and, oh my gosh, I quit smoking and now I've gotten worse. So that's how that works. Goblet cells, they react to any type of foreign invader. They get a little overactivated in times when people have respiratory issues and they start producing a whole lot of mucus. Their goal in a healthy person is to trap dirt and particles, trap it in that thick slimy sludge. The cilia sweeps it out and you cough it out. It's a pretty efficient system until you add things to it like allergens, chemical exposures, and smoking. Nitroglycerin, as I talked about, it dilates the coronary arteries. This results in increased blood flow. We want to get more blood circulating so we can get that fluid out, and hopefully we can get it circulated to the kidneys where eventually the patient receives a diuretic and they're able to pee it out. So I got this little acronym here at the bottom, POND, that kind of makes you think the patient's drowning in their own fluid. So position, allow the patient to get in a position of comfort. We're not going to get them on the stretcher and you're not going to lay them straight down. As soon as you get somebody on the stretcher, they're like, is this thing set up any farther? Put it all the way up, the next thing you know, you got their head between their legs and they can reach up and touch the back door because they're sitting straight up. That's because it helps them breathe better. The next acronym, or next word in the mnemonic is oxygen, and of course nitroglycerin, and then diuretics, that's a paramedic skill. We don't see the results of diuretics in the field, but the sooner we can give them, the sooner patients experience relief. In CHF, congestive heart failure, we've also, since we've added CPAP, the CPAP is also helpful when treating near drownings. The CPAP is also helpful in managing the shortness of breath and hypoxia in near drowning victims. The mechanism by how this works is similar to CHF, and the management is the same. This case, the fluid came from an outside source rather than the body producing its own. So the problem in a near drowning, water has entered the lungs along with lots of other bacteria and such, and there's an inflammatory response, there's fluid production by the body, and there's the outside foreign fluid that came from the water. So when you apply CPAP, we can hopefully push some of that fluid out into the vascular space where it can be eliminated. Your body does much better with fluid in the bloodstream than it does with fluid in the lungs. And here's this acronym for you. Any questions about any of the CPAP or airway stuff? We've got a CPAP out back there. We're going to practice with it. I think you guys all know about breathing treatments. Yes, sir.
Could you maybe expand on adjusting the PEEP? When do you know you need to go up and do it?
So when you're just on the PEEP settings, on the front of the valve there, we'll mess with it over here in just a minute, but that screw valve on the top, when you tighten that, it comes out of the box set with a PEEP of 5. When should we go up to 15? When should we go up to 10, 20, or whatnot? When should we advance it? If the patient continues to experience shortness of breath, their O2 sat is not increasing. We don't want to get it out of the box and go, shoot, these people's really bad, and just dial it up to trend 20 right off the bat. They will not wear the mask. 20, increasing the end airway pressure by 20 right off the bat is not comfortable. They're not going to like it. They're not going to adjust to it, and they're probably just going to rip it off, and the benefit that you would get from this is not going to happen. So if you start with 5, which is what it comes set at, and then you slowly every 5 minutes or so increase it by increments of 5, they can adjust to that. When they take it off, they will feel like they can't breathe without it. So you've kind of, in a sense, made them dependent on it. In the hospital, when they get ready to discontinue CPAPs, they slowly titrate the PEEP down, just like we have to slowly titrate it up. So if the patient continues to have shortness of breath, you're not seeing the results that you think you should, you can increase this by increments of 5 every 3 to 5 minutes. Really, there is no set determination of when you should adjust or how long you should wait in between. Provider discretion. I mean, there's a lot of gray area in EMS and in protocols and such. We're teaching people to be good clinicians, make good decisions, that kind of thing. based on your patient and what they look like. So just be sparingly with it, don't crank it all the way up right off the bat.
So if they're improving, don't even touch it.
If they're improving, you ain't gonna mess with it. Exactly, if 5 of people is enough, so if something is measured at 160 millimeters of mercury at sea level, and it's probably a little bit less here because our altitude's like 1,500 feet, and you're changing it by increments of 5, and that's proven to make a difference, 5 makes a lot of difference. And if you turn that thing to 20, that's an increment of 15. That's like taking somebody from here and immediately placing them on the top of Mount Everest or something. I mean, you've changed the atmospheric pressure that much. Well, it'd be the opposite way because you're adding it, but still, you're changing the atmospheric pressure that much when you dial the dial down. Any other questions? All right, let's take us 5 or 10 minutes here and go smoke, do whatever you need to do, and we'll get started back with the nausea vomiting.